Okay, here we are. We are doing EKG cases from the 2019-2020 class. It's our competency exam that year. This is a rapid review. This is intended for residents who just want to go over a bunch of EKGs really quick. So we're going to be quick about this to save time. So EKG competency number one, we look at this EKG, we look for any problems. We notice that the rhythm is pretty regular here. Let's see if I can turn this pointer on real quick. Yeah, so the rhythm is regular here. If we count the rate, it's 300, 150, 100, 75. It's a little bit faster than 75, maybe around 80, 85, something like that. And it's pretty regular. Really rapidly, I see P's, and P waves and QRSs and T waves. So anything that's regular like this, going about 75, is sinus rhythm. That's what this is. Number two, so we look at it just right off the bat. They give us a rhythm strip down here. This is usually like lead two. There's our partial lead two up there. But the rhythm strip down here, which is continuous, looks pretty regular. So let's check rate. 301. So from here to here is 300. From here to here is 150 or so. It's going about 300, 150. If we look around, it's going about 150, and we do see P waves. So again, those P waves reveal that it's coming from the SA node. So this has to be sinus tachycardia. If we don't see the P waves, then we think about a supraventricular tachycardia. So be real careful, because sometimes you just have to wait and say, that is a P wave. So this is sinus tachycardia. Everything else looks fine. Number three, here we go. We're looking around. They don't give us a rhythm strip on this one, so maybe that's a clue that they want us to look around a little bit more. So the star of the show here is the ST elevation. It is in V1, V2, V3, V4, and V5, a little bit in V6. So this is an extensive anterior septal wall MI extending into the anterior lateral wall. Remember, V1, V2, V3 are all the anterior septal leads. V4, 5, and 6 are the anterior lateral leads. So this is a pretty bad MI. Okay, number four, we look at this. Again, we've got a rhythm strip happening on the bottom, and just eyeballing it, other than it looking fast, everything else looks pretty good. If I try to make a case for do I see P waves, I look down here. I don't see a lot of P waves. I see a QRS and a T. I don't see anything before that. This next QRS, I don't see anything around here. Let's check on the rate and see how fast this thing's going. So we try to find an R wave that lands on a straight line here, a vertical line. So we go 300, 150. Again, we try to get over here, 300, 150. So it's going about 150, but I don't, as opposed to the other one, I don't see anything that I can make out as a reproducible P wave. So in this one, we've got to call this supraventricular tachycardia. We can't make the case that it's coming from the sinus node if we don't see a P wave. So supraventricular tachycardia. Case number 5, this is a pretty easy one, and you should be able to recognize this when you see it. This is the famous torsade de point. This is turning of the point. You see how these leads kind of get big and then they get small again, get big, get small, get big again. So this is a real famous lead. It's usually associated with an R on T phenomenon, and so perhaps there's an R wave happening on the T, and you begin to see the torsades starting up in this particular strip. This looks like a pretty continuous strip. Number 6, let's take a look at this. First off, the thing that kind of strikes it looks regular. The P wave issue is kind of debatable. The thing we're going to be asked to make a judgment on are these big, massive, long QRSs. And you think, well, what the heck am I looking at? Well, see that little guy right there, that upward little depolarization? That really is an R. This downward has to be what comes after R. S, right? So that's a little S wave, and that's an R prime, really. So this is the rabbit ear. This is sort of the famous rabbit ear, like you're seeing over here. See it right there? There's the R and the R prime. There's the R and the R prime, a little bit different. Look, you don't really see it much over here. And you do see it right there, teeny little R. There's an S, and there's the R prime. You don't really see an S prime in this one. So this is an R and an R prime. In other words, this thing, the QRS, the normal QRS, has got to be greater, it's got to be less than 0.12. And so these are milliseconds. So less than 0.12, and it is greater. So from the distance of that beginning of that little R prime all the way over to here, that looks like mainly like 0.18 or 0.2. So it's definitely big. So whenever you see the R or the R prime pointing up in V1 or V2, it's right-sided, because V1 and V2 is anterior septal, but it's over the right ventricle. So this is right bundle branch block, okay? And over, if it had been on this side, that would be left bundle branch block. Case number 7, we're looking around here, and we see some weird looking waves, that's for sure. It looks pretty regular. I see P's and what looks to be some kind of a crazy looking QRS down here. The thing we're supposed to look at is we're noticing an S wave in lead 1. We're noticing a big, deep Q wave in lead 3. And then we see an inverted T wave also in lead 3. So this is one of those famous rhythms that we're always supposed to try to remember. Sometimes we overlook them, but they're really fun when we see them. This is that famous S1Q3T3 presentation. Again, S wave in lead 1. That's an R. So the downward depolarization after the R has to be an S. Q, first downward depolarization before the R wave, and an inverted T wave. Associated supposedly with pulmonary embolism. Sinus tachycardia is supposed to be the most common rhythm in pulmonary embolism, but perhaps after the hemodynamics have stabilized, this might be more in line with their association. Next case, number 8. As we look at this, looks pretty regular, but the star of the show again are these big, massive QRSs. Definitely bigger than 0.12, longer than 0.12. So the depolarization is downward in V1 and 2. That means it's going towards the other direction. So this is anterior septal. That means the axis of the main axis of this vector is going towards the opposite side, which is on the V6 side, the anterior lateral side. So because it's upward in this area of the heart, we call this left bundle branch block. Okay, so 2 nice little caveats for right bundle branch block. We would see it positive here. Left bundle branch block, just remember, if it's wide and positive, it's a left bundle. Okay. If you can't remember anything else on your ACLS, remember they're going to throw something like this at you every time. If it's irregularly irregular and there are no visible P waves, it's got to be atrial fibrillation. And atrial fib can look like so many different strips. They can fool you. These are called fibrillation waves up here, kind of a nice example. But this is fibrillating atria. You don't even see a well-formed, quote, P wave at all. All right, so the atria are just fibrillating. It almost looks like V-fib, except we've got R waves in there, right? So atrial fibrillation, irregularly irregular, no visible P waves. Next case. What do we see on the rhythm strip down below in lead 2? Well, it's irregularly irregular again. And there are no visible P waves. Uh-oh, it's atrial fibrillation again. Another great example. Next case. Does it look regular? No. Is it regularly irregular or irregularly irregular? It is irregularly irregular. Are there visible P waves? Reproducible? No. Again, atrial fibrillation. Next case. Is it regular or irregular on the rhythm strip down below? It is irregular. If you were dancing, you couldn't keep time to that rhythm, right? And some of us can't keep time to anything. So it is irregularly irregular, no visible P waves. It is atrial fibrillation, once again. And don't you hate it when people try to trick you like that? Look at the last case. Rhythm strip on the bottom, lead 2. Is it regular? No. Is it regularly irregular or irregularly irregular? It is irregularly irregular once again, and I don't see any visible P waves. Therefore, once again, doggone it, we've got atrial fibrillation. So, we've done our rapid review. Hope this was helpful, and we'll see you next time.